Now we're going to review some key differences between palliative care and hospice care. Palliative care is appropriate at any stage of a serious illness, including for people who have ALS, because it's intended to be an extra layer of support alongside whatever disease-directed treatment or not someone with ALS may have elected. It can be provided alongside any life-prolonging treatments or interventions that they have chosen, such as BiPAP, CPAP, and feeding tube. Palliative care is available in the hospital, in clinic, and at home through home-based palliative care programs. Palliative care is intended to focus on the multidimensional suffering that arises from living with and through a serious illness, such as physical symptoms, but also psychosocial suffering, spiritual concerns, as well as any practical issues or concerns that arise. Palliative care affirms and values life, but also at the same time recognizes that someone with a serious illness is going to face an inevitable decline over time and wants to help support and plan for end-of-life care that is appropriate to that person in terms of what's most important to them, what their goals, priorities, and values are. Hospice care is a separate entity in the healthcare system from palliative care. It is specialized care for people who have a terminal illness whose physicians estimate the person has a prognosis of 6 months or less if the disease continues on its natural course. To be in hospice, you have to actually elect it, so you cannot accidentally find yourself in hospice care. Hospice care is dedicated to symptom management to help someone be comfortable at home or wherever they live for whatever time they have left. For people who are on mechanical ventilation or a breathing machine, they aim to facilitate helping the person transition compassionately off of the respiratory support to allow them natural death with comfort and dignity when they're ready. Hospice care is not so much a place, but rather a service that goes wherever the person is. They go to wherever the person is at home, in a nursing facility, or wherever that person might be. Hospice does have the capacity to offer inpatient care for someone who has an unmet symptom need that needs constant nursing management at the assessment of the hospice nursing team, but it is not a place that people can go and reside. Hospice focuses on the multidimensional suffering arising from serious illness, including the physical symptoms, psychosocial concerns, spiritual concerns, as well as practical issues, and is intended to be dedicated care for people who are declining due to being at the end of life. The goals for both hospice and palliative care is to maximize symptom management and to maximize, therefore, quality of life for the person living with and through the illness, as well as their caregivers and all of their loved ones and care partners. Both are intending to help navigate decision-making about care that aligns with the goals, the values, and the priorities of people living with ALS, their caregivers, their loved ones, and their care partners. They both also intend to support the emotional, the physical, and the spiritual needs of people living with and through ALS and their family members. Respiratory failure is the most common way that people who have ALS die, and that's because our chest is full of muscles. And because ALS affects the muscles get weaker and weaker, meaning that the lungs are less and less able to get rid of carbon dioxide in the body and bring in oxygen. The other thing that happens is that there's progressive weakness of swallowing, and those things together make it harder and harder for people with ALS to manage their secretions from their lungs, from their mouth, and to get air in and out. In order to prevent a crisis to arise when these symptoms are getting worse over time, it's really helpful to think through what would make the person most comfortable, what would honor their dignity and be respectful of what's most important to them in terms of their goals, their values, and their priorities. In order for someone to be able to enroll in hospice, they have to be eligible for hospice. And those criteria reflect what happens when someone is declining from ALS and they're coming closer to the end of life phase. That includes breathing difficulties, and especially when they're not on a mechanical ventilator, they're using BiPAP and CPAP settings through a mask. Swallowing impairment, meaning that they're having more and more difficulty getting food and drink in, especially for those who are not using a feeding tube. Worse mobility, so people are having harder and harder time getting around, including sometimes if they have a power wheelchair, that they basically are unable to move. People who have ALS sometimes experience a really rapid progression of their disease. Instead of it being over years, sometimes it can be over weeks to months. People who are experiencing that are eligible for hospice sooner than someone whose disease is progressing over years. And the person is experiencing problems with recurrent infections, such as respiratory infections, what doctors call aspiration pneumonia, or recurrent urinary tract infections, such that they're being hospitalized over and over again. So now let's talk about what hospice care does include. It includes all of the medications needed for symptom relief, durable medical equipment, such as bedside commodes, urine bottles, things of that nature. It provides a hospice care team that comes to the home at a time that is agreed upon by both parties. That includes the hospice nurse. There's a home health aide that can come a couple times a week to help with bathing and care needs. There's a social worker, there's a chaplain, there's a hospice medical director, and then many hospices also have additional services that are such as pet therapy, massage, music, things of that nature. Hospice also provides a 24/7 phone triage nurse that family members can call anytime, 24/7. If there's a concern that comes up, they need guidance on what to do, they forgot what dose of medication to do next, and there's a nurse on the other line, on the other end of the phone, who can walk you through what to do. Important things to remember that hospice doesn't provide, though, is they don't provide 24/7 custodial nursing care, meaning that they're not coming to your house and they're not there 24/7 to provide day-to-day, hour-to-hour nursing care. And they also don't provide room and board. Next, we're going to talk about something that healthcare providers refer to as medical aid in dying, which allows terminally ill adults to self-administer life-ending medication. This is not a federal law, but rather a law that some states within the United States have approved. Each state has its own set of eligibility criteria, requirements regarding the number of requests, any waiting periods, any residency requirements, and roles of the healthcare clinicians. What's universally true across all of these different states' rules is that the person has to be able to self-administer, and they have to have the mental capacity to be able to do that. When someone has a serious illness, sometimes one of the things that they consider is whether they could voluntarily stop eating and drinking. This is actually a legal option that people have. We recommend, though, that when someone considers doing this, that they also elect hospice along with proceeding with stopping eating and drinking voluntarily, because they will need symptom management, they will need support, and so will their caregivers if they're going to carry through with this. Someone who is already dehydrated and has already not been able to take in a lot of fluids might have a prognosis of days, compared to someone who's well hydrated and then decides to stop receiving medical nutrition or voluntarily eating and drinking might have a prognosis of several weeks. People who have ALS can choose to stop using their ventilator, whether it's a ventilator that is providing them support through a mask or through a tracheostomy. This is not considered them taking their life, but rather compassionate care for someone who's at the end of life and has decided that they no longer want to use a life-sustaining measure. We recommend highly that this be done with the direct supervision and guidance of either a physician or a hospice team. And that's because the person coming off of the respiratory support will have symptoms, and we want to make sure that they're as comfortable as possible. It's essential to think through when this would be done so that the right supports and medications can be available to keep the person comfortable for whatever time they might have left once they've stopped using the respiratory support. As caregivers, it's important to think about you and your own emotional and practical support needs. It's important to begin conversations early when thinking about end-of-life preferences with people who have ALS so that it doesn't become a crisis later on. It's important to think about who the healthcare power of attorney should be, designating that person, thinking about any thresholds that the person with ALS might want to set. It's important to think about having grief counseling and spiritual support available for caregivers because grief is a process and it's not so much an event, and it's actually a bunch of emotions, not just one emotion. This whole experience of being a caregiver to someone with ALS requires that the caregivers also have their own supports because it's a lot to go through.